Welcome to the Deep Dive. Today we're jumping into something pretty amazing, the journey of your blood. I mean, think about it. Every single second, it's delivering everything your body needs, everywhere. It's this incredibly complex dynamic system, and definitely not just a set of rigid tubes, right?
Not at all, far from it.
So our focus today is a deep dive into hemodynamics, basically the physics of how blood circulates. But we're zeroing in on the vessels themselves, your arteries and veins.
The containers, as you put it.
Exactly. We're going to unpack Chapter 19 of Boron and Boulpaep's Medical Physiology, specifically the part on arteries and veins. Our goal here is to take all that dense info, make it clear, conversational, explain everything from the ground up,
And connect it to what you actually see clinically. That's key.
Absolutely. We want you to have those aha moments where it just clicks. We've got the source material right here, and we're ready to walk you through the really important stuff.
It really comes down to understanding the blueprint, These physical laws govern how everything gets delivered and taken away. Getting this foundation right is, well, it's a huge step.
Okay, so let's start with the grand tour. The big picture of hemodynamics, like we said, studying the physical laws, focusing on the vessels. And the first big point, not rigid pipes. Different parts look different, do different things.
Totally. It's super adaptable. Think of it in maybe three main functional sections. First, you've got the arteries, the distribution network, carrying blood away from the heart.
Right.
Then there's the microcirculation. That's your arterioles, capillaries, venules. This is the crucial bit for diffusion and filtration, where all the real exchange happens.
The business end, basically.
Pretty much. And finally, the veins. They're the collection system, bringing everything back to the heart.
So let's trace that path. Starts with the single, huge aorta, branches out like crazy to the capillaries, then gathers all back up again.
It's an incredible branching pattern. You go from that one aorta to literally billions of capillaries, then back to just one or two big veins merging into the vena cava.
And the key thing is, as you go through these branching levels, a bunch of parameters change, often quite dramatically.
Yeah, and these changes aren't random. They're specific adaptations for function. If you sort of picture it, the number of vessels, their individual size, the total area they take up, and how fast the blood moves, it all shifts in really interesting ways.
Let's start with just the sheer number of vessels.
Mm-hmm.
One aorta, right? Then maybe 10,000 small arteries, 10 million arterioles, leading to something like 40 billion capillaries. I mean, the number just explodes.
It's staggering. And here's a cool detail. When you're just resting, only about a quarter of those capillaries are actually open and carrying blood at any one time.
Wow, okay. And then it all comes back together, collecting into fewer and fewer veins until you get to the vena cava, heading back to the heart.
And that massive increase in vessel count obviously affects the size of each individual vessel. The further out you go, the smaller they get. The aorta starts out, about 1.1 centimeters across?
Yeah, pretty big.
But the tiniest capillaries, they're down around 3 micrometers. That's a huge difference in scale.
Okay, but now for something that might seem a bit backward at first. The aggregate cross-sectional area. This isn't just one vessel's width. It's like adding up the area of all the vessels at a certain level, side by side.
Right. Imagine taking a slice through the entire system at that level. And a fundamental rule here is that the total area of the daughter vessels branching off is always bigger than the area of the parent vessel they came from.
Always.
Always. And this increase in total area really takes off in the microcirculation. Now, you might think, okay, billions of capillaries, they must have the biggest total area.
That sounds right. So many of them.
You'd think so. But actually, the peak aggregate cross-sectional area happens just after the capillaries, in the postcapillary venules. If you factor in that only about 25% of capillaries are open at rest, the total area of these venules can be, get this, about 1,000 times bigger than the aorta's cross-sectional area.
1,000 times. That's incredible. So if the total area peaks there in the postcapillary venules, what does that do to the blood speed? Something's got to give.
You got it. It's a direct result of what we call the principle of continuity, basically conservation of mass. The total volume of blood flowing past any point per second, the total flow has to be the same everywhere in the circuit.
Okay, like water in a river widening out.
Exactly. So if total flow equals the aggregate area times the average speed, then wherever that area is biggest.
The speed must be slowest.
Precisely. So because the area is maximal in those postcapillary venules, the average speed of blood flow plummets there down to about 0.03 centimeters per second. Super slow.
Compared to the aorta, which is like 20 to 50 centimeters per second?
Right. A massive, roughly thousand-fold difference. And it's perfectly designed. You want the blood moving slowly, right where all that crucial nutrient and waste exchange is happening.
Makes perfect sense. Slow down for the delivery and pickup.
Exactly. And just to add one more layer, while that total flow is constant, the flow through any single vessel varies wildly. We're talking like 10 orders of magnitude difference.
10 orders. Wow.
The aorta carries the full cardiac output, about 83 milliliters per second, but a single typical capillary, with only a quarter open. We're looking at maybe 8 times 10 to the negative 9 milliliters per second. Incredibly tiny flow, perfectly suited for exchange at that microscopic level.
Okay, we followed the blood through the vessels, but where does all this blood actually hang out in the system?
Yeah.
And how long does a round trip take? The total blood volume, maybe 5 liters for an average person. It's not spread evenly, is it?
Definitely not. That's a really important point. Rough numbers. About 85% of your blood is in the systemic circulation arteries, capillaries, veins out in the body. Maybe 10% is in the pulmonary circulation going through the lungs.
And the rest?
The last 5% or so is actually inside the heart chambers themselves at any given moment.
Okay, but here's the kicker, right? The part with big clinical implications. Within that systemic circulation, most of the blood isn't in the arteries.
Not even close. About 3/4 of that systemic blood, which works out to around 65% of your total blood volume, is sitting on the venous side of things, especially in the smaller veins.
65%. So the veins are basically the body's main storage tank for blood.
Absolutely. That's why we call the venous system the crucial volume reservoir, and this has huge implications.
Like what?
Well, think about what happens if those veins suddenly widen, increase their capacity. Blood pools there. If enough pools, not enough gets back to the heart, cardiac output drops, and you could faint, syncope.
Right, I see, because that's where most of the volume is.
Exactly. And just quickly, that central blood volume, the heart and lungs, that acts as sort of an adjustable filling reservoir for the left heart. In heart failure, especially left-sided failure, that regulation can get completely messed up.
Okay, so that's where the blood is. How long does it take for, say, one red blood cell to make the whole loop, the circulation time?
Yeah, circulation time. Generally, for the whole circuit, it's roughly a minute, give or take. For just one specific part, like through the heart's own coronary circulation, it might only be 10 seconds or so.
I remember reading about old ways to measure this, like injecting ether.
Yeah, historical methods. Inject ether, time how long until the person smells it from their lungs, or inject something bitter, time until they taste it. Interesting, but honestly, they don't tell us that much physiologically these days.
Why not?
Because circulation time is fundamentally just the ratio of the volume of blood in the system to the flow rate through it, TH/VFD. So if circulation time changes, it could be because the volume changed or because the flow rate changed or both.
Ah, okay. So it's ambiguous.
Exactly. Think about heart failure again. Someone might have low cardiac output, which would slow things down, or they might have increased total blood volume, which also increases transit time. So just knowing the time is longer doesn't tell you why. It's more complex.
Gotcha. Okay, that leads us perfectly into the driving force behind all this. Pressure. There's a big difference between the systemic circulation pressure and the pulmonary, right?
Huge difference. Systemic pressures are much higher. The average pressure in the systemic arteries is around 95 millimeters of mercury. In the pulmonary artery, the average is only about 15.
Why such a big gap? The heart pumps the same amount of blood to both sides, doesn't it?
It does, yeah. In steady state, cardiac output is the same for both ventricles. The difference is resistance. The systemic circulation just has a much, much higher resistance to blood flow than the pulmonary circulation.
So it needs a higher pressure push to get the same flow through.
Precisely. And in both systems, you see the pressure drop as you move away from the heart. You have the pulsatil pressure from the heartbeat, systolic, diastolic, and that pulse gradually dampens out. Plus, pressure fluctuates a bit with breathing, too. We generally talk about a high-pressure system, left ventricle out to the systemic arterioles, and a low-pressure system, starting from the systemic capillaries all the way through the veins and the pulmonary circuit.
Okay, here's a question that trips people up. Where does pressure drop the most in the systemic circuit? You'd think maybe the tiniest vessels, the capillaries.
That's the intuitive guess, for sure, but it's actually the arterioles.
The arterioles, even though capillaries are smaller individually.
Yep. And this is super important. A single capillary does have high resistance. Boisseau's law tells us resistance goes up massively as radius goes down, to the fourth power, actually. But the key is the number of vessels.
Yeah, back to the aggregate idea.
Exactly. There are billions of capillaries arranged in parallel, so even though each one resists flow quite a bit, their combined or aggregate resistance is actually much lower than the resistance of the arterioles upstream.
So the arterioles, fewer number but acting like choke points.
They are the main site of resistance. That's where the most significant pressure drop happens in the systemic circulation. Understanding this resistance distribution is also crucial for figuring out local pressure, like in a capillary PC.
Right, you said it's not just the average of pressure before and after.
No, it depends on the balance of resistance before the pre-capillary resistance or versus after it, post-capillary resistance or post. The fact that normal capillary pressure is around 25 mmHg tells us that usually our PRA is greater than our post.
And what's the significance of that?
Clinically, it means that capillary pressure tends to follow the pressure downstream in the large veins. Think about standing up for a long time. Gravity increases the pressure in your leg veins. Because our PRO is usually higher than our post, that increased venous pressure gets transmitted back, raising capillary pressure.
Which pushes fluid out, leading to swollen ankles.
Exactly. Fluid moves into the interstitial space, and then if you elevate your legs, venous pressure drops, capillary pressure drops, and the fluid can move back in. Simple but elegant physiology.
And this resistance isn't fixed, right? The arterioles can change their diameter.
Absolutely critical point. Vascular smooth muscle cells, especially in the arterioles, are constantly adjusting the vessel diameter, vasoconstriction, vasodilation. This dramatically changes local resistance and alters the shape of the pressure drop across that arteriolar segment. These changes ripple upstream and downstream too.
Okay, so let's dig into the vessel walls themselves. Their elastic properties. They're not just passive tubes.
Not at all. They have structure, usually 3 layers. Intima, the inner lining, medio, middle, often muscular, and adventitia, outer connective tissue. Capillaries are the exception, just the intima, basically endothelial cells on a basement membrane.
And within those layers, there are key components.
4 main building blocks. First, endothelial cells, that single, continuous layer lining everything. Crucial for lots of functions.
Okay.
Second, elastic fibers. Think of these like rubber bands. They handle most of the stretch at normal pressures. Made of elastin and microfibrils. They're everywhere except the tiniest capillaries and venules.
Then there's collagen.
Right, collagen fibers. Much less stretchy, maybe only 3–4% stretch. This is more like a tough jacket, usually a bit slack, but they provide strength and prevent overstretching when the vessel really expands. Also everywhere, except capillaries.
In fourth.
Vascular smooth muscle cells, or VSMCs, found in all segments except capillaries. Importantly, when they're relaxed, they don't add much elastic tension. Their main job is active contraction squeezing the vessel.
So because these walls are elastic, the simple flow rules like Poiseuille's law don't quite cut it.
They're a starting point, but yeah, reality is more complex. Poiseuille assumes rigid tubes. In living elastic vessels, the pressure-flow relationship is definitely nonlinear. As you increase the driving pressure, the elastic vessel stretches, its radius gets bigger. Bigger radius means lower resistance. So flow increases more than you'd expect just from the pressure increase alone. It's a steeper curve than the linear one Poiseuille predicts.
That makes sense. The pipe gets wider as pressure goes up.
Exactly. And this elasticity leads to another really interesting and clinically vital phenomenon, critical closing pressure.
Critical closing pressure, what's that?
Well, if you drop the driving pressure really low, something strange happens. Resistance suddenly shoots up, and below a certain pressure, typically around 6 mmHg normally flow, can just stop completely. Even if there's still technically a small pressure difference.
Flow just stops. Why?
It's the combination of the passive elastic recoil of the vessel wall trying to collapse inward, plus any active tension from those vascular smooth muscle cells squeezing down.
The VSMCs again.
Yep. And this is where it gets really important clinically. If you increase the active tension, say, through sympathetic nerve stimulation during stress or shock, it shifts that whole pressure flow curve. Resistance goes up at all pressures, and that critical closing pressure increases.
So it takes a higher pressure just to keep the vessel open.
Exactly. In severe hypotensive shock, the body clamps down hard everywhere, trying to raise blood pressure. Critical closing pressures in places like the limbs can skyrocket to 40 mmHg or more. Meaning blood flow to that limb could completely stop even if you can still measure, say, 30 mmHg pressure difference between the artery and vein. The vessel itself is clamped shut. It's a stark example of the vessel wall actively controlling flow.
Wow. Okay, let's talk more about how vessels adapt. Compliance, tension, stability.
Right. So distensibility is the general term for how stretchy vessels are, but the more useful measure is compliancy. It's simply the change in volume for a given change in pressure. Think of it as the slope on a pressure-volume graph.
Steeper slope means more compliant, easier to stretch.
Exactly. A highly compliant vessel can take on a lot more volume for just a small increase in pressure. But importantly, compliance isn't constant. As the vessel fills up, it gets stiffer, so compliance actually decreases at higher volumes or pressures. It's nonlinear.
And this leads to that idea of arteries as resistors and veins as capacitors.
Precisely. Arteries handle high pressure but don't hold a huge volume. Their compliance is decent, but it doesn't change dramatically with normal pressure swings. Because their radius and therefore resistance stays relatively stable, we call them resistance vessels.
But veins are different.
Totally different. They hold a lot of volume, and they are incredibly compliant, especially at the low pressures they normally operate under, say 0 to 10 millimilli G.
And that high compliance isn't just the elastic fibers.
Not primarily in that low pressure range. It's largely due to a fascinating change in shape. At very low pressures, veins are kind of collapsed, maybe elliptical. As pressure rises just a little, they pop open into a nice round shape. That geometry change lets them swallow up a large volume increase with barely any pressure rise.
That's why they're capacitance vessels. They store volume easily.
Exactly. They're the volume reservoirs.
Yeah.
And you see this difference starkly. If you take a piece of vein, like the saphenous vein from the leg, and use it for a coronary artery bypassed graft.
Right, putting it into the high-pressure arterial system.
Yeah. That vein, used to low pressure and high compliance, suddenly faces arterial pressure. The same small volume change now causes a much bigger pressure spike inside it. It behaves very differently, which has implications for the graft's lifespan.
Okay, this seems like a good time to bring in Laplace's law. It sounds important for understanding how walls handle pressure.
Absolutely fundamental. Laplace's law basically says that the tension, T, within the vessel wall needed to counteract the outward pressure depends on both the pressure and the vessel's radius, so TAR.
Tension depends on radius, too, not just pressure.
Crucially, yes. Imagine tension as the force trying to pull apart an imaginary slit along the vessel wall. And here's the big insight. Vessel walls are built to withstand the tension, not just the pressure itself.
How does that play out?
Let's compare the vena cava, a big vein, to a tiny capillary. The vena cava has a huge radius, even though the pressure inside is relatively low. Multiply them together, large radius, moderate pressure, you get significant wall tension.
Okay. Now, the capillary.
The capillary has a higher pressure inside than the vena cava, right? But its radius is minuscule, so higher pressure times tiny radius equals...
Very low wall tension.
Exactly. And that's why capillaries, despite the pressure, don't need thick, strong walls with lots of elastic tissue. Their tiny radius keeps the tension manageable for just a thin layer of endothelial cells. It's brilliant. The amount of structural stuff, like elastin and collagen, in any vessel wall correlates directly with the tension it has to bear.
Not just the pressure. That's a key distinction.
Huge distinction. And that tension-radius relationship isn't linear either because of the different properties of elastin and collagen.
How do they work together?
At low stretches, it's mostly the stretchy elastin fibers taking the load. They're compliant, so tension rises relatively slowly. But as the vessel stretches more, you start engaging the much stiffer collagen fibers. They're like ropes that limit further stretching. Once they engage, the wall gets much stiffer, and tension rises very sharply. It's a safety mechanism.
And this changes as we get older, right? Arteries get stiffer.
They do. That's a major consequence of aging. Arteries tend to get less desensible, stiffer, partly due to some fibrosis and changes in collagen.
What's the effect of that?
Well, think about the surge of blood entering the aorta with each heartbeat. In a young, compliant aorta, that volume increase causes a certain rise in pressure, the pulse pressure. In an older, stiffer aorta, the same volume increase causes a much bigger jump in pressure.
A higher pulse pressure.
Right. Partly because the baseline compliance is lower, and partly because the artery is already operating on that steeper, less compliant part of its pressure-volume curve.
Okay, one last piece here. Active tension from the smooth muscle and how it all relates to stability.
Right. We can't forget the VSMCs actively contracting. That active tension adds on to the passive tension from the elastic elements. Now, why is elasticity so important for stability? Imagine a vessel made only of elastic fibers. It would naturally adjust its size to match the pressure stable.
Okay.
Now imagine a vessel with only fixed muscle tone, no elasticity. If pressure drops slightly, the muscle tone might make it collapse completely. If pressure rose slightly, it might just keep expanding until it blew out. Unstable.
So the combination is key.
That's the crucial takeaway. Real vessels have both elastic components and smooth muscle. The elasticity provides that underlying stability and ensures that when the smooth muscle contracts or relaxes, the vessel radius changes in a graded, controlled way. It prevents the vessel from just snapping fully open or fully shut.
And when that balance goes wrong,
You see problems if the passive elastic components get damaged, like in an aneurysm or varicose veins. The vessel wall weakens, enlarges, and might eventually rupture if the tension gets too high.
makes sense.
Or, conversely, if active muscle tension becomes dominant, perhaps because elastic elements regress, you can get conditions like Raynaud disease.
Where fingers turn white in the cold.
Exactly. The cold triggers intense arteriolar smooth muscle contraction. Without enough opposing elastic recoil, the vessels can clamp down completely, shutting off blood flow to the extremities. It really highlights how vital that balance between active and passive tension is.
Wow. Okay, so let's try to wrap this up. As we finish this deep dive, what are the big things to take away?
Well, we've seen the incredible range of adaptations across the whole circulatory system, right? From the aorta down to capillaries and back. We saw how resistance, especially in the arterioles, is the key player in determining how pressure drops.
And how that aggregate cross-sectional area dictates flow velocity, slowing things down perfectly for exchange in the microcirculation.
Exactly. Then we looked at the vessel walls themselves, the interplay of compliance, the Place's law, and wall tension, and those four key components: endothelium, elastin, collagen, and smooth muscle. Understanding tension, not just pressure, is huge.
And how the balance between the passive elastic parts and the active smooth muscle provides stability, and how imbalances lead to disease like aneurysms or Raynaud's.
You got it. It's all interconnected.
Definitely. And mastering these concepts, really getting how these elegant systems work together, it builds such a strong foundation for anyone in medicine or science. Every deep dive like this just gets you closer.
Absolutely. Keep digging into it.
So, maybe final thought for you to chew on. Think about how deeply these physical properties are used. The radius of a single capillary, the stiffness of an aging artery shape, not just blood flow, but our actual health, our risk for disease. What kinds of new diagnostics or even treatments could come from understanding these biomechanics even better? It's pretty fascinating to consider.